Welcome to Surgeon's Log 2020, Case Archives of the Skull Base and Beyond, a webinar presented by the North American Skull Base Society in association with Global Brain Surgery Initiative. I'm your host, Dr. Walter Jean of George Washington University. If you've enjoyed this and other episodes, don't forget to click the subscribe button on our YouTube channel so that you don't miss any future episodes. For now, put on your learning hats and enjoy this episode of Surgeon's Log 2020. I will introduce our panelists and guests. Top of the marquee is, of course, Dr. Lawton. He needs absolutely no introduction. He's the president of the BNI, and he will be the discussant to end our session. Dr. Michael Wong is my co-course director of Surgeon's Log 2020. And he is an associate clinical professor of neurosurgery at UCSF. And with him is one of his residents, Kunal Ragor, who is a PGY5 at UCSF, who will be our trainee panelist. And away we go. I'm going to go ahead and share my screen now, and we are going to go into the slides. So for those of you, well, this is a brand new series, so let's, why am I sharing that slide? This is, wait, stop sharing for a second. I need to get out of presenter. Oh, okay, well, that's no good. All right, let's see what we can do here. Let's go back to the top slide, and then, can you all see my slide now?
No.
I'm not able to see it.
Okay, one second. How about now?
Yes.
Yes.
Okay, so the format of this webinar is very different from the ones that you're used to probably. It is really hinged on discussing the decision-making process of cases. So we will start each session with showing a trainee panelist a case that is a mystery to him or her. Dr. Ragor, you agree that we've never met before, and I've never shown you any tips, or he's like a magician on the stage. I'm showing you my hands. We've never met before, and we haven't discussed this before, right?
Correct.
So he will try to verbalize what the audience is thinking as we work through the case, and I will be the little voice in his head asking him, hey, what about this? Hey, what about that? Whereas he will hopefully verbalize the audience thoughts about, hey, maybe we should do this, maybe we should do that. After working through all the way to the surgery, I will then show what I actually did and what I actually think. And then, of course, the end of the session will be, the podium will be turned to Dr. Michael Lawton for his discussion on what we did right, what we did wrong, and so on and so forth. So away we go. So welcome to our webinar, which I have already discussed. By the way, we will leave some time for Q&A at the end. The man who lost his face. This is a 32-year-old man with a chief complaint of headache, dizziness, nausea, and vomiting. The headache was the first symptom and started about 5 days prior to presentation. All the other ones kind of followed suit. When he showed up in the ED, he is awake, alert. The right face is completely gone, and that's how he lost his face. And the other cranial nerves were intact, and the rest of the exam were unremarkable. So you called after they already done some work, and they got a CT scan that was consistent with the MR. Here's your gradient echo. Your initial thoughts on that?
So we're looking at an axial, what looks like probably a GRE, a gradient echo MRI. And what I see is a lateral Pontine, what looks like a cavernous malformation. It looks like it's sort of eccentric to the left, and certainly comes to the surface on the left side. Okay,
so you can have the rest of the images here. And your thoughts about location, and does this change any of your thoughts you already gave me?
Mm-hmm. So doesn't change a whole lot. Looks like it's a mostly posterolateral Pontine cavernous malformation. The middle panel looks like it shows that it's a little bit more superior in the pons. And then I think in the leftmost image on that coronal image, I think what we're seeing maybe, I don't know if that's a DVA that we're seeing on the leftmost image, or if it's just some more of that hemosiderin ring of the cavernous malformation. But I don't think it changes too much what I was thinking before. I think it certainly explains the. Sorry,
does it surprise you that he looks as good as he does with this picture?
Not particularly. I think a lot of times when patients have these brainstem cavernous malformations, they may have some cranial nerve deficits that emerge with serial hemorrhages, but they don't typically look as bad in my brief experience as patients with like a Pontine hemorrhagic or Pontine hypertensive hemorrhage, who typically look more severe than the brainstem cavernous malformation patients.
All right, so you're in the ED and you're on a desert island. There's no one else to help you, no other person to bounce your thoughts off of and whatnot. And all the ED docs looking at you going, okay, what do we do?
So I think I have a fairly good sense of what the diagnosis is. Certainly, there can always be metastases. AVMs are always on the differential, but given the appearance on the MRI, I think cavernous malformation is highest. I think this patient needs to be admitted to the intensive care unit for close observation, blood pressure control, and then planning for surgical intervention.
Okay. Any other diagnostic study or maneuvers or procedure you want to do to add to your information?
We have a CT scan beforehand, and then we have this MRI. I don't think an angiogram would be of any particular or specific benefit in the case of a cavernous malformation. I think the one thing is, in terms of thinking about approaches,
All right, let's stop there for 1 second.
Sure.
Well, a lot of times, they get things done before you even get involved. So
Sure.
In this case, I was, while I was getting involved, this was already going on. This is the only thing that's relevant. This is the only thing that anybody saw on this thing. What can you tell the audience what it is, and what is it important? Is it not important?
Sure. I think so. We're seeing the angiogram here, and it looks like there's probably a DVA with this caput medusae appearance on the angiogram that we're seeing.
So what are your thoughts? Is it going to interfere with whatever you're going to do to this person? How do you treat this thing? How do you wrap your brain around this before you make your plans?
Right. So with respect to the DVA, I think the goal is to avoid, to first of all know that there is this DVA, to be mindful of it in the operation, but then to particularly avoid the DVA and not ligate the DVA when you're in there surgically.
All right. Okay, now he's in the ICU. He's sitting tight. Nothing's happening much with him. Family's looking at you going, what are you going to do to us? So
actually, the first thing I just thought about when planning for surgery, I think probably we would want to get a neuronavigation scan with fiducial markers, and then probably get DTI tractography just to mark out the corticospinal tracts as well. But in talking to the family, I would explain to them that this has had a looks like there's hemorrhage within the cavernous malformation. There are some neurologic deficits associated with that. the cavernous malformation, it looks like it's coming to the surface posterior and laterally in the pons. I think surgical resection is reasonable. Certainly,
Okay, let me
one
stop you
option
there.
is,
Let me stop you there
sure.
for a second. So let's say that hypothetically a family says, "Hey, you're talking about surgery. I'm scared out of my wits. I'm just going to walk out of here." What's the downside of that?
Sure. I guess what I would explain is that the downside is that we know the natural history is that this will continue to hemorrhage over time, and as it hemorrhages, the risk of serial or worsening neurologic deficits increases.
How
And
likely is that
after the
going to
first
happen?
hemorrhage, we know that I forget the exact numbers off the top of my head. I think I would say with very high certainty, this will hemorrhage again and can lead to further neurologic deficits.
Right, that's very good. I mean, the numbers are actually somewhat helpful when you talk to the patient's families, right? Because they always want to know, like you're saying that this is going to happen. Well, how likely is it going to happen? And I think the definitive paper might be the one out of Tiantan from Beijing, where they looked at 1,000 of these. And you're right, it's quite high, and we'll talk about that at the end. I think Dr. Lawton may actually mention the numbers and whatnot. So walking out and not getting intervention is kind of a scary thing because it may explode again, right? All right. So if you're going to operate, what is your goal?
My goal surgically would be to get a gross total resection of the cavernous malformation and some of the hemosiderin ring without obviously and while minimizing any potential additional neurological deficits from the surgery. I think what I would explain to the patient's family is that there is a very high chance of at least a temporary neurologic deficit as a result of the surgery, including facial paralysis or weakness, but that typically any temporary neurologic deficits tend to improve over the course of a few months.
And why do you have to take it all out? What is actually the goal? Can you verbalize what you actually achieve if you take it all out versus just take out the clot or whatnot?
Oh, I see. Well, a cavernous malformation is a venous angioma, so I think if you don't take it all out, there's still a chance that it will continue to hemorrhage.
Right. So it's for the future, right? It's for
right.
It's for really mitigating the possibility of rebleeding, or you're back in this AD again, next year, the year follow or whatnot. All right. So your therapeutic goal is total resection. You've got your DTIs, you got all of that. Now, okay. Let's see, what's the next slide here? Oh, by the way, it continues to be a problem. So he tells you that, over the last 2 or 3 hours, he's now having some right-sided arm numbness. The right face is having paresthesias, and he is now seeing double on and off. What was your timing of intervention before he tells you the story and after he tells you the story?
Right. Before telling me the story, the timing of intervention for me was not actually going to be emergent. It was, probably on the order of within the next few days, or within, probably within the next few days, try to resect this. Now that he's having ongoing symptom progression, I would try to push it a little bit more quickly, and I think plan to do it within the next day or so.
Okay, now this is a very important point. Why did you say you were going to wait a few days?
Well, I think so. Typically, the risk of additional hemorrhage, while there is an increased risk of additional hemorrhage, it's not typical that it will re-hemorrhage within the next day or two. I think it's the hemorrhage risk is more longer term. So I don't think you need to treat this as an emergency immediately resect it. But certainly now that there is symptom progression concerning for rehemorrhage, I think pushing that timeline up makes sense.
Do you think waiting a couple of days actually gives you a benefit?
It also would help in some ways to reduce some of the inflammation, I think it theoretically could help also just from a medical standpoint, make sure that you have time to get any additional tests depending on approach that you may need, and to sort of dot your I's and cross your T's prior to surgical intervention.
All right, so as the story evolves, this family actually is completely on board with you. They're saying that these numbness and diplopia is really scaring the bejesus out of them, and they really want whatever intervention that you're going to do done quickly and sooner rather than later. Now, how are you going to get there?
Can you go back to that MRI? Yeah. So again, we have a sort of more superior posterior lateral cavernous malformation, eccentric to the left side. I think there are a few possible options for approach. One is a retrosigmoid craniotomy, craniectomy, and then a trans MCP approach after mapping out the root entry zone of the trigeminal nerve.
All right, for our international audience, can you explain what MCP means?
Oh, sorry, the middle cerebellar peduncle.
Okay.
Another potential approach is a lateral supracerebellar infratentorial approach. I think those are probably the two main approaches given this posterior lateral location of the cav-mal.
So you're really using two corridors with the same door, though, right? I mean, either way, you're talking about a retrosig craniotomy. The one corridor, the first corridor you mentioned, is a straight retrosig to the middle cerebellar peduncle. The other one is a more supracerebellar infratentorial, almost like a modified lateral pineal sort of thing. Okay.
Right.
What are you going to choose, and why?
I think I would probably choose the retrosig and then enter the pons or enter through the middle cerebellar peduncle. In terms of why, I think just looking through the MRI again, I think that gives you good access to the cavernous malformation, and
well, you want to choose the most direct path with the least angulation. Right. You want to choose the shortest path that gives you the widest exposure. So you think that through the middle cerebellar peduncle, that would give you the biggest the corridor to take this out, right?
Right.
Okay. There's no right or wrong answers, and I have a slight small suspicion that that's exactly what Dr. Lawton would do for this one, but we'll hear about his thoughts in a little bit. Okay, it's my turn. I was going to wait a little bit longer than you did. In my initial encounter with this person before the symptomatic progression was that I was actually going to send him home and really let him cool off with the thought that the hematoma would liquefy. And instead of dealing with a solid clot, I would have a much more liquid clot, and I could go through the clot to the CM, to the cav-mal. When he started progressing, he was so nervous that he said, you know, if you're not going to do something to me, I'm going to leave. I'm going to go to Hopkins. You know, that's always happens to all of us in Washington, and so on. So, and I thought it was reasonable that if he's progressing, I don't know when he's going to really crump and perhaps have a catastrophic event that I didn't expect happen. And that would be really, really bad. So I decided to go earlier rather than later. I thought that this thing actually came to the surface at the super trigeminal safe entry zone. I thought, you know, see, you can see the red mark there. I actually thought that this the hematoma actually came to the surface there, and if so, it's you know, first of all, it's a safe entry zone, and second, if the hematoma gets there, I'm a very practical guy. You know, if the hematoma makes the opening to you, then you should take it, kind of a thought. And with that, my thought was that I was going to go subtemporal transtentorial. You can see that I also did a mapping for the navigation, and I thought that that actually gave me a most direct route. With the risk, of course, is that I'm actually putting some pressure on the temporal lobe as I mobilize it away from the surgical field, and that might cause a seizure or badness. Whereas your posterior fossa approaches are much more, you know, it doesn't bring the temporal lobe to bear, and especially since this is the left temporal lobe, you got Lebet in your way potentially as well. So there are definitely pros and cons. I think that this might be the shortest and most direct route. I was worried that if I went supracerebellar and infratentorial, I have to dive down, back down. So this was the route I thought was most direct, and that's why I chose it.
There are a couple of questions from the audience regarding whether you consider doing a posterior petrosectomy as an approach to this lesion.
I didn't think that the petrous bone was in the way of this thing. And I think that, first of all, you're a little bit above it. And second of all, I think you're a little bit more posterior to the ridge. So I actually did not think about doing that, but like a Kawase, like, you know, if you took down the anterior petrous apex, that might make a little bit more room. But it turns out that this is actually much more posterior than the Kawase region, as I will show you in a little bit. Okay, so I put in lateral. I tipped the vertex down. I did not do a lumbar drain. And to be honest with you, if I went back to doing this tomorrow again, I might have put a lumbar drain. And I don't know why I didn't think of that. I thought I was going to get enough room by mobilizing the CSF and tipping the vertex down. And that was going to be enough. And it turns out to be okay. This was the incision that we did. Pretty big. We probably didn't need to go that big. And I will show you the video. Let's see whether it'll play. So we are, oh, I should have taken the nav. So subtemporal, cutting the, are you able to hear the narration?
No.
Oh, okay. Well,
There's no narration there.
okay. So the hematoma came to the surface, and I got in there. And after the hematoma was evacuated, I was able to find the cave mal. Yeah, I'm hearing the narration in my ear, so it's kind of confounding. You can see that we're moving posteriorly to find the cave mal, and here's trying to find the anterior edge of it with a curved hook, being as gentle as I can. The bipolar is turned down to very, very low. Here's the back edge in the gliotic plane. Trying to catch the inferior edge of the cave mal there. And after cutting away some of the attachments, there's some venous bleeding. I didn't want to chase that because I was thinking that that might be the DVA. And that was luckily sufficient to stop the bleeding. There's residual inferiorly. And then carefully dissect it and remove the inferior aspects of it. So here's your field. Fourth nerve, draining vein of DVA, we think, SC8 branches. And there was that end of the surgery. So if you know anything about me, I like this system of talking about corridors, craniotomy, and modifiers. So this, in summary, the corridor is subtemporal, the craniotomy was simply a posterior temporal, and the modifier in this case was a tentorial incision. The position was lateral with the vertex down. The incision was upside down U, and bone opening was a rectangular posterior temporal, and then a U-shaped dural opening. Here's the result of the resulting MRI. The hematoma was fortunately removed. The cavernoma seemed to be completely removed. And if you believe there's this little enhancement here, that might be some of the DVA hopefully left intact. He turned out okay for the most part. His diplopia was significantly exacerbated post-op and it's all in all directions, right-sided hemibody hemianesthesia. Now I have to say that I was criticized for the monitoring things. So I monitored SSEP during this, and there was a change in the SSEP near the end of the operation. By that point, I thought that I had committed already the operation, that most of the cav mal was out, so I continued with it. And he had the hemibody hyposthesia. Post-op day 3, he had some language problems. Remember, this is on the left side, but gradually that improved, and otherwise he improved the baseline. This was him in clinic just a couple of weeks ago now. And he's quite a little bit unsteady on that turn, as you saw, and his hemibody anesthesia still remains. But otherwise, he did a pretty okay. So that is the end of my presentation. Kunal, you did a remarkable job. I want you to be my neurosurgeon, and I would turn the podium over to Dr. Lawton now, and let's see what he thinks about.
Sorry, Dr. Jean, before you do that, just a couple of questions from the audience. Did you consider doing a DTI to look at the tracks in preparation for the surgery, and did you do any kind of special studies to look at the vascular anatomy, especially looking at Lebet, given the approach?
Well, there was an angiogram done, and that's how we found the DVA that I showed. Lebet was not in the way of the approach, and that was just pure luck. Well, I didn't see it on the angiogram, and being in the way of the approach, and it was certainly in the operating room, it didn't show its face as in my way. The DTI was another point that some of my trainees brought up, and a lot of times they're smarter than you, what I thought was that the tracks are what they are. I mean, the cav mal and the hematoma actually does your work for you. We're going in where the hematoma comes to the surface. We're not going to disturb any tracks there. And when you're in the middle of dissecting, you're guided by the cav mal and where it goes. You're certainly not going to disturb anything outside of the cav mal, and you're staying as close to the border as you possibly can. So I didn't think that the tracks were going to really influence what I did, having decided that my goal was to take this thing out exactly as Kunal verbalized, the reasons for all that. So with that, I return the podium to Dr. Lawton, please.
Okay. I'm attempting to share my screen. Let me know if you see my screen. Can you see it?
No, we're still seeing you.
Hold on a sec.
Oh, there you go.
Okay. All right. So let me just first begin by commending you, Kunal. I think you did a tremendous job. I see you're very well trained. I'm going to take partial
Thank you.
credit for that, not only because I had you for 2 years, but also because I trained Adib, and he's now training you. So by transitivity, I think that principle is I will take some credit for your good decision making.
Absolutely, appreciate it.
Walter, congratulations to you for putting this on. I think this is a very nice format. Reminds me of how we used to torture our residents in San Francisco on every Thursday morning with these case presentations, board style. And I think it's a very useful format. So I'm going to give you my critique. And let me see, hold on a second. There, did that advance?
Yeah.
Okay. So this is my experience. I would say that cavernous malformation surgery is really like a game of chess. It's about analyzing all of the different factors, analyzing your various options and moves, and making the best choices. And I think that's particularly critical when it comes to brainstem cavernous malformations, because the stakes are high and wrong decisions can lead to real disadvantages that cost patients their outcomes. So I really feel like it's important to invest some time studying the anatomy, doing exactly what we dragged you through in this case, looking over the films, weighing the different options, and just making a critical assessment of what's best based on that anatomy. So about surgical selection, this was a symptomatic hemorrhage. This was appropriately evaluated from an imaging standpoint. So I have no criticisms there. If we look at what's out there to help us decide whether or not to operate, this is something that I published with Roxy Garcia and Mike Ivan years ago. This was a brainstem cavernous malformation grading system that looked at 5 variables that were relevant to outcome: size, whether it crossed the midpoint, whether there was a DVA, the age, and the hemorrhage. And if you assign points, kind of the way that we assign points for AVMs, you can grade these things. This particular case would have had a brainstem cavernous malformation grade of 1, based upon its small size, not crossing the midline, presence of a DVA, young in age, and by that I mean less than or equal to 40, and bleeding in the acute phase. So by all criteria, if you look at how that scale helps you, the low grade cavernomas basically have very good outcomes, and you can have a very low likelihood of worsening the patient. This is data from that same 100 or so patients that validates that. And at some point, as the grade marches upwards, you're going to cross a line, just as we do with brain AVMs, where the risks are going to be prohibitive. So this one clearly fit within that comfortable and acceptable limit. Now, you correctly identified 2 of the 3 approaches, the retrosig trans MCP and the retrosig lateral skit, supracerebellar infratentorial. The third was Walter's choice, the subtemporal transtentorial. And a couple of comments on that. I think the lateral skit would not have been your best choice, so I'm glad you didn't choose that. The reason being is that this is an approach that works really well for the midbrain. It works really well for the thalamus if you want to extend upward. It works less well when you try and go down. As you try and go down, the cerebellum gets in your way, and other things, more importantly, the superior cerebellar peduncle get in your way. And if you violate that, you pay an enormous price. So pushing the skit upwards is great. Pushing the skit downward is not great. And so I'm happy to see that you didn't choose that. There's one of the slides that Walter showed where the trajectory of the approach gets you to the very top of the lesion, but does not get you to the bottom. And to get to the bottom would have been difficult had you chosen this. Now this is just a screenshot from Walter's video that he showed. And this is the reason why I would not have chosen this approach. You know, you can see two retractors in the field. You can see probably about 2 centimeters of lift on the temporal lobe. As Walter said, he got lucky. The vein of Lebet was not in the way. There certainly are ways to move around the veins, but can you see my mouse?
Yes.
Yeah, here's a bridging vein. These are very easy to avulse. The vein of Lebet can also be right in the middle of your field if you're unlucky. So that's an issue. It's the dominant hemisphere. This is not insignificant amounts of retraction. And based upon the story, the patient felt it. You know, he had language difficulties and obviously transitory, and they didn't amount to anything permanent, but he felt it. The other thing is, you know, making a tentorial resection, I think, is not trivial as well in a similar vein. And it's because, you know, you can have a tentorial venous sinus, you can have hidden anatomy either within the leaflets of the tentorium or underneath. And so there is an element of aggravation if you get into veins or difficult venous anatomy. This was also lucky in that there was no sphenobasal sinus or sphenopetrosal sinus or any of the other variants of the venous anatomy that can run in those leaflets on their way back to the posterior circulation. So I just say this because it would not have been my first choice. This is a case similar to what Walter showed us, the case here. And the reason I wanted to show this is because I operated on this kid not long ago. He was operated twice using the subtemporal transtentorial approach in another state. And in both, after both surgeries had residual, underwent gamma knife radiosurgery for this because the surgeon had enough. And still the patient then represented with another hemorrhage. And so I think some of the problems that I tried to diagram here with these arrows, to get to the top of these lesions, you have to elevate the temporal lobe. That's what this arrow is meant to show. To get to the bottom part, you have to lift even higher on the temporal lobe. And these are the kinds of analysis that you have to look at when you are weighing your trajectories. I would have chosen the transmittal cerebellar peduncle approach. I think it's a wonderful workhorse approach. This was that case, that same one I just showed you. This worked out great for that kid. You can see the vector is direct. There's no angulations, there's minimal retraction, and it's just a dead-on shot. Some comments about this approach. This is a nice illustration showing a couple of things. You know, the way this is drawn makes it seem like you go into the CP angle, you get to the lateral aspect of the pons here, and you go in through the peduncle and you get a nice shot at the malformation. You can see the descending corticospinal tract here pushed forward. That's not always the case. The idea of DTI was raised, and I think that's important because you always want to make sure that the malformation hasn't pushed that tract in a lateral direction or directly in your line of transgression here, and that's important to know. But this actually, this illustration does a bit of a disservice, and I'm going to elaborate on that in just a minute. So the rest of my comments are really about technique, and I want to just start with the extended retrosig. We'll talk about the petrosal fissure, we'll talk about the safe entry zone, and we'll talk about trajectory. So extended retrosigmoid, we didn't get into the exact details, Kunal, of what you would have done for your extended or for your retrosigmoid. We only said retrosigmoid, but I think there are retrosigmoids and there are extended retrosigmoids. And my personal feeling is that there's a huge difference. The retrosigmoids that you do for tics and for hemifacial spasm and for simple lesions in the cerebellum are fine for those. But when you're talking about a brainstem cavernous malformation where you want degrees of freedom, you want some ways to look in different corners of the hematoma cavity, the resection bed, it's really important to create space. And the way you create space with the retrosigmoid, in my view, is to skeletonize the sigmoid, take it from the transverse sigmoid junction all the way down to the jugular bulb. And when you do that, you can easily turn a cranie from there. And more importantly, your dural flap ends up getting absolutely flush with the petrous face. So you've maximized the corridor, Walter's corridor idea. You've maximized that with your bony removal and even maybe extended it. That's why the extended term is there. Because if you can pull that sigmoid sinus a little bit forward, you gain precious millimeters of room. And that is important because of this slide. If you look at the blue arrow, most retrosigmoids get you going right along the petrous face and into the CP angle and just right along this diagonal here. But for this lesion, it's not really enough. You've got to actually tilt that vector this way. It's about a 30-degree tilt from the normal petrous line here to the line directing to the axis of the lesion. And so if you look at what that means, you're changing your angle, and this magenta point here is meant to make the suggestion that you've got to not go along the subarachnoid cistern like that previous diagram showed us here. But what you've got to do is actually move that entry point back. If you look at where the green arrow now intersects the tissue, it's all the way back here. And so that's where the idea of this petrosal fissure comes in. So the petrosal fissure, I like to think of the petrosal fissure as the Sylvian fissure of the cerebellum. And these are some artist renditions here. I'm going to show you some cadaver specimens in a minute, but we're all drawn to the cistern. It's like this, this light that we want to just immediately go to. But in fact, what you want to do is you want to split the petrosal fissure. It's that space between where the superior lobule curls downward and the inferior lobule curls upward. And in fact, the angle of the CP angle is really where these two intersect here at the at this back part here. And you've got to spend some time opening that up. Here's a nice Lawton view showing that superior lobule here. This is the edge coming down. This is the inferior lobule over here. This is the inferior lobule over here, and you can see how they come together right in this little angle here. So this is the CP angle, and this is the petrosal fissure as it continues on. Here's another view without the arteries to obscure, but you can see the line of this here, the line of the inferior lobule here, and the petrosal fissure that continues outward. So if we open up the petrosal fissure like this retractor is meant to show, what we're seeing is that we're actually able to walk more laterally out the cerebellar peduncle, all the way out to a point somewhere here where the fovea converge and where the peduncle sort of dives into the tissue. And that's really what you're looking for. So here's now a top-down view. And so if you remember, you know, some of our early shots into the CP angle get us going this direction. But if you look at where the petrosal fissure takes us, it's all the way back to here. And that's really important because remember that green arrow that I mentioned before? This is the vector of that green arrow. It's going in this direction to get to the central pons. If you only want to go to the anterior surface and touch the surface of the pons, you can ride the cistern. But if you want to get into the central pons and get around a lesion, you've got to go in this direction. So that's really important. And I think, you know, I'm going to show you a video that demonstrates that. So then that really defines the entry spot on the cerebellar peduncle. That's where we actually dive in. And these are just from our brainstem cavernous malformation book showing various so-called safe entry zones. This is, I think, probably the best among them. It's right out here or even further because in my opinion, it truly is safe. So here's that case example. You can see here the lesion square in the lateral pons, and the middle cerebellar peduncle is a beautiful approach. This is very similar to Walter's case, and I'm going to just play this 3.5-minute video here so that you can see. So here we are opening up this petrosal fissure. You can see the lobules, they're adherent to one another. You can see the arachnoid that bridges across. But just as we split sylvian fissures by following the vessels inward and outward, we follow the ICA branches inward and outward. Here you can see in this case this enormous DVA that's in the CP angle. And we're going to have to work our way into the pons, but underneath and posterior to that DVA. This is a view of the trigeminal entry zone. So I've completely now freed the DVA from the brainstem. And you can see this is that blue arrow that we talked about. It's the wrong trajectory. If you were to just follow this in, it's going to skive tangentially to the malformation. So what I need to do is I need to split the fissure even wider. So I'm actually going more lateral into the petrosal fissure, getting extremely lateral as far as I can. And you can see, once I've opened the fissure, you still find peduncle at that very lateral point in its course. And here now, look at the difference in the trajectory. Now we've got a square on view. I've taken my entry point as far lateral, almost at the level of the sigmoid sinus, and it's directly in line with the lesion. And that's really what you have to achieve to do a good MCP approach. Now, I showed this little piece here because this DVA was enormous. It had little fingers. In my view, it's okay to take a little finger of a caput medusa, which I'm doing here because it's in my way, but it's not okay to take the trunk. The trunks are different, and those have to be preserved. Here you can also see a few more little fingers of that caput medusa, but they're hiding the malformation, which is immediately next to it. And you can see here, getting to the capsule, getting inside the capsule, and you can see the blood internally. So now we're actually at the malformation, and you know, half the battle with malformations in the brainstem is your approach and getting to there. So when I get to this point, I feel good, and now it's just a matter of the finesse of getting these things out safely. And they're not always that interesting from a spectator's point of view on a video, but Walter showed you the instruments of his preference, the right angle hook. I really prefer or like these round knives, and I have a whole set that has these thin, straight round knives, these angled, smaller round knives. There's a whole rack of these round knives that allow me to work these angles. And here, this is after I've gone around the capsule, freed it up. You can see that, as in this case, you want to get an en-bloc resection if possible. If you can get an en-bloc resection, then you know all the different elements of the malformation are contained within it. This is to show that we're all the way on the deep side, at the deep edge of the pons. And here I'm just showing you those nice, clean gliotic margins that are within the central pons. And here's the overview. You can see, here's that DVA, here's the middle cerebellar peduncle. This is how far lateral we've gone through the petrosal fissure. Here's the fifth nerve, completely untouched by this. And tentorium is up here. This is really Dandy's vein, but DVA is becoming Dandy's vein, and it's entirely preserved. And this is just an overview of that extended retrosigmoid. You can see how the sigmoid is right here. The flap is pulling it forward. We've created space. We've created that room to change our angles.
Before I have a question before you move forward.
Yeah, sure.
You know, as I mentioned, I'm kind of a simpleton approach. I mean, my case, the hematoma came to the surface, and I thought, okay, there's your way to enter. The case that you showed, there was no hematoma, but the malformation didn't come to the surface. And how do you choose the exact spot where you enter the middle cerebellar peduncle? Is it simply the shortest distance to the malformation, or is there a particular way you choose that exact spot and you make that incision?
Yeah. Let me see if I can take you to that that really nice.
Right. Yeah. Right there.
Okay. So when I get that kind of a view on my stealth, and I line it up in both the axial and the coronal trajectory, and I'm square in both, that's where I make my entry right there.
Okay.
So that's what I'm looking for. And all of that dissection leading up to this point was to create that corridor and that line of sight to this kind of a view. And then I know that I'm far enough lateral on that peduncle that the patient's not going to notice that I've been there. This was a high functioning executive. She woke up with absolutely no deficit whatsoever and was discharged on the next post-operative day. You can see how, if you follow this track, it really is quite lateral on the peduncle. This is the kind of a line that you want to get in. And to your point, it's tempting to want to come in here and dive this way, but the DVA was in the way, the trajectory was better from this kind of a shot, and that's why I chose it.
Actually, on that point, Dr. Lawton, one of the audience member asked, do you ever, how much does the presence of the DVA factor into your selection of an approach?
Yeah, it's a good question. I would say it almost never factors in. I think the selection of the approach is really the dominant factor, and the DVA is just, I guess we could throw that into Walter's modifier bucket. It just modifies a little bit the way that you dance around the corridor. I don't let it dissuade me, though, from choosing the right approach.
And for these approaches, for the retrosig, especially these expanded retrosig, how often do you use a lumbar drain to help with the brain relaxation?
Never. In fact, I can't even think of a time where I use a lumbar drain. There is always a cistern that I go to as my first maneuver, whether it's the carotid cistern on a pterional approach, whether it's the cisterna magna on a supracerebellar approach. There's always a cistern that you can get to that is far quicker and far more reliable than a lumbar drain. So retrosigs, absolutely not. You can get to the cisterna magna in 20 seconds. I have just a few more slides and I'll wrap this up. This is just to make the point that it's very easy to leave a residual when you're working in a long brainstem corridor. You've got your craniotomy, which limits you. You've got your subarachnoid portion of your approach. You've got, in this case, a parenchymal segment, and you've also got an intralesional segment. And there is a blind spot in this. When you're looking this way and the blind spot is over here, then it's very easy to leave a remnant. So you've got to be really careful to look in those little corners. Another point I'd like to make is just about the lesion axis, and by that I mean, hold on one sec. By that I mean some lesions are in complete alignment with the approach vector, the approach trajectory, and for those it's very easy to see everything that you want to see. Other cases, the lesion axis is maybe perpendicular to your approach trajectory. And in that case, it's really prone to leaving remnants or creating blind spots. And so I kind of have a right angle rule where I draw a line and I look at the right angle portions of this lesion that are off axis, and I look really carefully in those little pockets, those corners that might be hiding something. So I think we've covered all these points. I think Kunal, you did a wonderful job. You chose the approach that I would have chosen. I think for that, I'm going to give you an A+.
Okay. Thank you for that masterpiece discussion on the topic. I particularly like this format because it's only with real cases that you can actually get to the really nitty gritties of the approaches and the resections. And if you, a general discussion of the topic just doesn't get there, and maybe it doesn't highlight the points just as well with real life cases. So I really like this sort of format to bring out the absolute nitty gritty nuances, the granular details that we need to be outstanding masters like yourself. Let's get some audience Q&A going. Do we have, Michael, any
Yeah,
ready?
so a couple questions just came in. One is on the subject of maximizing resection for these corners. Would you ever consider putting an endoscope to take a look at those, those blind spots?
Yeah, I think the endoscope has value. I think for those of us who are in love with the microscope, we now have Kivo, which is part of the Kinevo system. So it's a whole lot easier for us to do that. Honestly, though, if you do a really good job with your decision making, you almost never need the endoscope. I think using your instruments to sort of pull tissue aside and changing your scope angles and really forcing yourself to look in those right spots. It's a mental thing. It's not an instrument thing. And you've got to just train your eye to look to those spots, anticipating or predicting where you're going to most likely leave a remnant or have a blind spot. You have to just say, okay, it's in this particular quadrant. I'm going to go to that quadrant now that I think I'm done, and I'm going to make sure that I see gliotic tissue on all sides. And endoscopes are just, they're clumsy, and I personally don't love them, but obviously I think for those who have been raised with endoscopes, they probably are more valuable to them.
Thank you. And then another question about for your retrosig craniotomy. Do you have any defined landmarks or specifications as to how large you make that or how you design that?
Well, yeah, there are lots of great landmarks. The Asterion is a great one for identifying the transverse sigmoid junction. I like the 1 finger breadth behind the external auditory canal as a landmark for where the sigmoid sinus is lying. I think 9 neurosurgeons out of 10 are afraid to get into the mastoid air cells when they work back there. And so they really struggle in doing a good skeletonization of the sigmoid. But there's really nothing to be afraid of with the mastoids. It's ENT territory, and we're not really as comfortable there, but you got to get comfortable there, and you have to be willing just to get into some air cells to find the sigmoid, and it's trivial, really.
Okay. And then both for Dr. G and Dr. Lawton, do you guys routinely get angiograms in preparation for something that looks obviously like a cavernoma?
I do not. I think a gadolinium-enhanced MRI will have a signature appearance for a DVA that will tell you that it's that. And in conjunction with the CAV-MAL, you'll make your patients a lot happier not subjecting them to an angiogram. That said, if there's any doubt, there have been, I can remember some very distinct cases of thrombotic aneurysms that looked a whole lot like a cavernous malformation. And we decided to do angiograms, and thank goodness we did, because if you get to a thrombotic aneurysm and you dive in like we've been showing you here on these videos, you're in for some hard times.
Yeah. And Dr. G, you mentioned about intraoperative neuromonitoring. For these brainstem lesions, what's your standard? What do you typically monitor?
Well, I'd like to get Dr. Lawton's answer on that as well. I think for this case only did SSEPs. And again, there's a lot of criticism about how you use monitoring. What if it changed at the beginning? What if it changed in the middle? What if it changes at the end? Whether you push forward or not with the operation. That's a minefield, and I don't know that there's a really right or wrong answer to this. Certainly if you're just beginning the resection and your monitoring changes, there's a potential of abandoning. Maybe you chose the wrong, maybe that's telling you that you chose the wrong approach. Or maybe you needed more DTI imaging and whatnot. But, near the end, if you're already 90% of the malformation is out, I don't know how you can stop at that point if the monitoring changes. So I would say that routinely you would use your basic monitorings. I'd like to hear Dr. Lawton's thought on that.
Yeah, I agree. I think monitoring up front, early in a case, might be of some benefit. Like if you're doing a fourth ventricular approach and you're mapping the facial colliculus, there's clear upfront value to mapping, but that's rare. And I think most of our decisions are based on finding the peel representation and not having to go through tissue. And so it really, as Walter said, comes at the very end of a case when you're already done. And I view it as a buzzkill. When you've done a great case, the thing's just about out and you're ready to feel wonderful, and your neurophysiologist chimes in that you've had a change, and it doesn't change anything. It doesn't stop you from completing your job. It doesn't really impact anything other than your mood. And so I've become very cynical. I almost feel like they're unnecessary, but because they're the standard of care, we can't not do that.
All right, we're about to wrap up here. I'd like to ask Kunal a question. What did you think about the session? Did you think that it was beneficial from a trainee point of view? How can we do it better? Having been in the
I
hot
thought it
seat.
was great. Oh no, I thought it was great. I think it was, as Dr. Lawton mentioned, I personally like the sort of oral boards style of questioning. I think for a resident, it is really nice. And then obviously hearing from a master is more than I could ask for. So I thought it was a great session.
Okay, so our time's up. We're hopeful that we can post this on the YouTube channel as a recording. This will move forward from now. I look forward to inviting you back, but all of you, back to discuss a different topic, a different case in the future. 2 weeks from now, we have an ear case to talk about coming out of NYU, and Michael Link will be the discussant for that. And with that, I thank everybody for their time. If the panelists can stay behind just for 1 second, I will bid the attendees farewell. Please join us again 2 weeks from now and sign up early. So attendees, we are signing off. Thank you for attending.